Hi, I'm here to talk about and share the practical approaches to using opioids, especially to do this within the National Opioid Use Guidelines. So today in this talk, I hope that we can get across the use of the opioid use guidelines, be familiar with their 5 modules, and to use the tools that they've advised a little bit more effectively in your practice. And then finally, what to do with the actual trials and tapering and monitor the actual practical use of the opioids themselves. The Canadian National Opioid Use Guidelines was launched around May 2010. It was a collaborative between many of the colleges across Canada and a huge key knowledge leader group. It's basically split up into about 5 modules and over 24 recommendations, and it helps guide you how to start a trial, how to screen for the best patients, and then also in those that we need to taper, how to deal with those things. There's a lot more tools in that you can find in those guidelines. What were they trying to do with these? We were really trying to find and improve safety in using these medications because they're tough to use. So the Canadian guideline for safe and effective use of opioids for chronic non-cancer pain, effectively the National Opioid Use Guidelines, is pretty comprehensive, but they've been updating the website at the National Pain Center in McMaster. Here you can see a made reference in this slide that you can pick up different parts of it and learn the modules and actually integrate tools into your practice through your smartphone and through the EMRs. So I encourage you to make use of that. So as we know, the effects of chronic pain is pretty severe. It's pretty much the whole person. It has effects on physical functioning. It really changes the way the mood and psychological functioning works. And then of course, what it does to the person's relationships, family, work, and school, let alone the costs it has on both the patient, their families, and society in general. Part of Module 1 in the National Opioid Use Guidelines is looking at all the factors that help us decide when we should even think about trialing opioids in a patient. So if pain is moderate to severe, if it has a huge impact on the function and quality of life, maybe maximized non-opioid type medications and strategies were already tried. Opioids may be very indicated for specific conditions like bony metastases, and that nothing else will be helpful for that. And then of course we're looking at building in safety to make sure it's actually appropriate for the patient, even though the pain syndrome is going to be treated well with opioids. Is the patient and the patient context safe to use? So that means compliance, patient consent form, that there's actually responsibility for the use and prescribing on both sides with the physician and with the patient themselves. In this slide, the opioid use guideline refers to one of the ways to screen for the risks with our patients, and this includes the opioid risk tool. So this is pretty easy. You can see in this tool there's a difference between the scoring systems for females and males, and this is applied to adult patients only. They really look at some major factors such as family history of substance abuse, personal history of substance abuse, age, especially within the working age, and the history of sexual abuse in adolescent time, in addition to any psychological comorbid conditions such as obsessive compulsive disease, bipolar, or schizophrenia and depression. These different scores just give you a guideline as to what risks and vulnerabilities that patient might have if they do start opioids. So it doesn't mean that someone can't use opioids, it just means that it heightens your awareness and maybe some supports and the boundaries with which you're prescribing this. So all of us have heard about the universal precautions in pain medicine, and these were well published, in fact, by Canadian authors some years ago. And it really is actually applicable for all medications, not just opioids. So obviously we have to have a diagnosis that's appropriate, the psychological assessment that helps us screen for any vulnerabilities of people who may use any medication inappropriately. Ideally, we want an informed consent, either both verbal or by written, that could be given out in the office. And in doing that, what we're looking to do is to make sure that expectations between patients and clinicians and even our pharmacists are aligned, that we're all on the same page. And the treatment agreement is very similar to the informed consent. It's akin to understanding that if something is not helping that patient meet meet their goals, then we've got to start shifting and reviewing the use of that medication. And in particular with opioids, if there is no major change in function, it really doesn't make sense to continue the opioids. And finally, what we're trying to achieve. So beforehand, there are some measures such as pain or function, sleep, function at work. We want to set out some objective goals so that we can measure if these medications are going to be effective. So you see in this slide is an example of the treatment agreement. In the National Opioid Use Guidelines that you can see on the McMaster website, this is one example that you can just pull down and use in your EMR. You're welcome to alter and add to it, but a summary of the content is to keep this medication use safe. And so some of the principles here is around single prescribers, letting the health care provider know when patients are going on vacation, taking time away, how frequent the follow-ups are going to be, setting expectations during the time when a new medication is being tried of what a patient should be doing to keep it safe, and also what the clinician is going to be doing to keep this safe. And then finally, to set expectations that if things aren't changing and improving function, then these medications have to come off. So this also sets expectation on review periods. In this slide, we finish off the other 5 of the principles on the universal precautions in the use of any medications for pain management. During this appropriate trial period for any new medication, but in particular opioids, somewhere between 4 weeks to 4 months allows you that time to add on any non-opioid medications, any other strategies to minimize the use and dosage of the opioids. And it actually helps one to replace any short-acting medications with longer-acting medications and see how that becomes a stable dose. So that trial of opioid therapy is quite active, and the follow-up is often a lot more frequent, once a week to every 2 to 4 weeks, but some regularity so that medications can be switched up, dosages can be switched up, and decisions on whether or not a drug is going to be tapered will be done. The other principles and precautions in the use of medications in general is always during this trial period is a review. And in particular with opioids, it's the 6 A's. So this is the analgesia, activities, any adverse side effects. What they say ambiguous drug-taking behavior or really medication misuse, the affect and emotional state, and then finally is our own accurate documentation. And that's kind of highlighted in point number 10, where we really need to document our conversations, our dosages, how they're using it, and what also are the functional goals that we're trying to match the medications to.